You can lock it.
That's right. Oh.
On behalf of the Pharmacists of Illinois, I want to bring attention to a critical issue that is threatening the viability of community pharmacies, not only in Illinois, but across the entire nation. That issue is the relentless pressure to drive community pharmacies out of business, particularly in underserved urban and rural areas. This growing crisis is being fueled by the unchecked power and greed of pharmacy benefit managers. Before I dive deeper into the issue, I'd like to take a moment to express my gratitude to a few key individuals here. First, a heartfelt thank you to Congressman Krishnamoorthi for organizing this event. Also, Edwin, for having us here, using your valuable time and your place to do this. Thank you. And lastly, to Heather Anderson, thank you for your bravery to talk about how PBM tactics are damaging patients. Okay, now I'm going to talk a little bit about the parasitic industry that is driving medication costs and putting pharmacies out of business. I'm not talking about drug companies, but rather the health insurance industry, specifically the pharmacy benefit managers that they own. These include United Health's OptumRx, CVS Health's Caremark, they also own the health insurance company Aetna, and Cigna's Express Scripts. These companies are part of an industry that is stacking profits at the expense of patients and pharmacies. In the United States, we pay 2.4 times more for health care than the next most expensive country. Just let that sink in for a second. Another way of putting it is we pay 340% more than the second highest country. Now here's the kicker. And yet, despite that staggering cost, when we compare wealthy nations, we are dead last in outcomes. Would anybody in their right mind say we're getting a good return on our investment for this? Well, turns out a few people would. United Health says so. CVS Health and Cigna, they all think it's great. Why? Because their business practices have driven them to number 4, number 6, and number 16 on the Fortune 500 list. Keep in mind, we have the worst outcomes of all the modern wealthy nations. These companies don't care about health outcomes. They care about enriching their shareholders and executives. They're not focused on improving care. They're focused on increasing profits year after year. In their eyes, patients are not people in need of care. They are just a means to a financial end. Their words may say otherwise, but their actions speak way louder. To say our healthcare system is broken barely scratches the surface. The practices of pharmacy benefit managers are one of the primary reasons our system is failing. PBM practices not only degrade the quality of care, but they also artificially inflate costs. I'm not here today to list every way that PBMs undermine affordable, high-quality care. Countless congressional investigations, hearings, and reports from the Federal Trade Commission have already done that. What I want to say is this. If we don't take 3 critical actions, our healthcare system will continue to spiral, becoming even more expensive with worse outcomes. The first action, we must rescind safe harbor that protects PBMs from anti-kickback laws. Second, we must make it illegal for an insurance company to own or be owned by a pharmacy benefit manager. And third, we must make it illegal for any insurance company or PBM to own pharmacies or any other health entity that makes their money from health insurance payments. This is a complex issue, but that's exactly how the PBMs want it. They thrive on complexity and confusion, but it doesn't have to be this way. We cannot let the complexity stand in the way of necessary reform. We must fix how we pay for health care, and that begins with reining in pharmacy benefit managers and restoring them to their rightful role as claims processors and claims processors only. All right, that's all I have. I now want to turn it over to Illinois' PBM reform champion, Congressman Raja Krishnamoorthi. Raja, thank you for your reliable and steadfast support of pharmacy and the patients we serve.
Thank you so much. Thank you. Well, Edwin, thank you so much. Pleasure. I just want to say thank you so much to Dave. Thank you to Edwin for opening up your wonderful store. And I've based on the traffic that has been arriving during this press conference, I can tell you're busy during the day. And the reason why you're so busy is because we have a pharmacy desert in most parts of the city. In fact, in most parts of the state. Dave has informed me, and others have too, which is something like 75% of the state does not have a pharmacy, 75% of counties, and that number unfortunately is growing, and that's why we're here today. I'm delighted to see my good friends from the pharmacy industry. The independent pharmacists are here today in force, and they are small business people, and they are members of the community. They give back, and so we want to make sure that no small business is put out of business because of an unlevel playing field with their competitors. And in this case, there's an unlevel playing field relative to pharmacy benefit managers known as PBMs. I want to talk a little bit about the ways in which PBMs are creating an unlevel playing field. There are two primary issues with PBMs. One is that they raise drug costs. And the way that they raise drug costs is by essentially creating this perverse rebate system where they get rebates from drug manufacturers for drugs that cost more than others. So guess what? PBMs ask that these prices be higher and higher so they can get bigger and bigger rebates. The problem is they pocket the rebates. They don't pass it along to consumers or residents of this community. Instead, they pad their profits. And the rest of us get their high prices. The big other way that they are hurting our system is they are killing off independent pharmacies. They are steering prescriptions to their mail order pharmacies instead of allowing for pharmacies like Del Car to fill those prescriptions. Not only that, but they're also steering the most profitable prescriptions to their own mail order pharmacies and leaving the less profitable and in some cases unprofitable prescriptions for Del Car and other independent pharmacies. I'd like to point out one other thing that the FTC recently highlighted in their report, which is these PBMs are also making a lot of money through something called spread pricing, which means that they are basically charging more to Medicaid and Medicare than what they reimburse to local pharmacies in filling prescriptions. They create a big spread. And so taxpayers are getting ripped off. And so when you combine all of these ill effects of the practices of PBMs, I like to refer to PBMs by what they really should be called, which is pretty big markups. That's what PBMs really stands for. And so with that, I just want to say a big thank you to Edwin. He has been in business, or his company has been in business since 1964. I saw a picture of it. And because of businesses like Edwin's and Del Car, I'm trying to take action in Congress legislatively with my staff. Anna points out to me, one of my staff members, that we are working on at least 3 pieces of legislation that we're going to continue to work on a bipartisan basis. One is called the FACT Act. Basically what this would do is it would allow for more transparency and require the Department of Health and Human Services to require PBMs to make transparent all of their practices in dealing with the federal government. 2, we have something called the No PBMs Act. And this would establish new public reporting requirements for PBMs that would prevent them from discriminating against local pharmacies. It goes to this issue of steering, which I talked about earlier. And then 3, we have the PBM Sunshine and Accountability Act. Again, it would mandate that PBMs report their aggregate rebates, administrative fees, and other revenue from drug manufacturers on their public websites. I have some other ideas with regard to PBMs, such as the fact that they should not be able to own their own independent pharmacies at the same time that they're acting as middlemen between payers and other pharmacies. I also think that this whole rebate system doesn't make sense, and eventually I'd like to see that either go out of existence or make sure that the rebates actually get passed on to consumers at point of sale or otherwise. But in the meantime, we're working on these pieces of legislation with Republicans. This is one of the few bipartisan issues which almost made it into the continuing resolution back in December, but ended up getting cut out at the last minute. I presume because of certain swamp creatures that exist in Washington, D.C. So, in any case, thank you again for your attention, and now I'd like to turn it over to Heather.
Good morning. My name is Heather Anderson. I'm currently receiving treatment for my plaque psoriasis and psoriatic arthritis. And I want to share my experience with the medication process. I was prescribed Stelara in January 2024 after waiting 3 weeks for my insurance to approve it. During that time, my entire body felt like it was on fire. Once the insurance finally approved it, Accredo contacted me. I told them I would call when I needed my shot, and everything seemed fine until the end of July. One day, I went out the front door of my house, which we don't normally use, and found my shot sitting outside. I hadn't ordered it, so I was caught off guard. When I brought the box in from the heat, I opened it to find that the shot had gotten hot. I immediately called Accredo to ask what to do. At that time, I was due for my shot, and the person I spoke with assured me that it was fine to take it. Unbeknownst to me, I wasn't speaking to a pharmacist. I trusted what I was told and took the shot. About 2 weeks later, my plaque psoriasis started returning. I spoke with Dave, the pharmacist I work with, and explained what had happened. He helped me as much as he could to get a replacement shot. However, Accredo initially refused to replace it, and my condition worsened. After weeks of back and forth, they finally agreed to send a new shot. However, they required me to pay another $150 copay, or they wouldn't send it. At this point, my arthritis had gotten so bad that I had to ask my boss to open up bottles. I was relying on my family to help me at home. After 2 weeks of frustration, they agreed to send the shot without the copay. Finally, I received the shot and took it. I'm sharing this experience because I believe that mail-order pharmacies are not an ideal option for many patients. I actually cried when I realized that Accredo saw me as a dollar sign, not as a person in pain. I could barely do my job, and the emotional toll of feeling like I wasn't valued as a human being hurt almost as much as the physical pain I was enduring. I work at a pharmacy, and I don't understand why I couldn't get my medication directly from there. If I had been able to, the whole ordeal could have been avoided. The reason I couldn't is because Accredo is owned by my insurance company. Thank you.
I should have probably introduced you. Heather is a pharmacy technician, and she's also a patient who has suffered from kind of poor treatment by a PBM that was operating a mail-order pharmacy that provided her with a shot for psoriasis.
Psoriasis and arthritis.
Okay, thank you.
Thank you.
Good morning, and thank you, Congressman. I'm so glad to have you here. This is a true excitement for me in my business. I want to first of all thank my father, Edwin Muldrow Sr., who started our business 65 years ago It's an honor and a privilege to be a pharmacist. I've been a pharmacist since 1992. Right now, we are in a desert. At first, in this community of North Lawndale, it was a food desert, which we exist here on 16th Street. But now, with much needed PBM reform, we're in a pharmacy desert as well. So right now, with the Walgreens that are around my location right now that have closed, I'm seeing an influx of patients that are coming to me and asking me, hey, can I have my medicine transferred to your pharmacy? And I want to take the business, but right now I'm unable to satisfy because we're just not getting compensated at the levels that we need to be. So for instance, I have an example right here. I had 2 prescriptions for some Eliquis. The insurance company paid me $552, but my acquisition cost from my primary wholesaler, AmerisourceBergen, was $727. So how can I, in business, whether it's auto business or hair care business, how can you dispense medication to a person that needs medication when we're not adequately being compensated? Because we have to, like any business, we have overhead, we have staffing, we have insurances, et cetera, et cetera. So right now, I just don't understand. I'm just wondering, when are we going to get some relief from the local, the federal level? Because no business can stay successfully in business with these type of profit spreads. So I'm just happy to have Congressman right here. I'm excited that he's leading the charge for us in pharmacy, because like many pharmacists in our profession, you know, we're dedicated, we're passionate to our customers, to our craft, and we just want to continue to provide service for our people and our communities, but we can't exist if we're not being adequately compensated for our services. So I just want to say again, thank you for Congressman being here. I look forward to the results that are coming.
Thank you, sir. Thank you.
Yes, from the pharmacy benefits manager, isn't there a conflict of interest, and what type of system reforms are you looking to put in place to improve the situation?
They are a walking conflict of interest. Everything they do involves a conflict of interest. So they're supposed to be a middleman, okay? But middleman means, in my opinion, you should be acting in the best interest of your client, whoever hired you to negotiate whatever it is. So for instance, payers, so health insurance companies or employers or even Medicare, Medicaid hire PBMs to act as a middleman to help negotiate the price of prescription drugs. But what they end up doing is they essentially get a kickback from those drug companies when they pocket the rebates that were otherwise supposed to be for the clients. So that's one conflict of interest, okay? And in the process, they keep they keep asking for higher list prices so they can get bigger rebates and kickbacks. So that's one conflict of interest. Another conflict of interest is when they're supposed to negotiate between payers and pharmacies for the dispensing of drugs. Well, what's going on is, as Edwin mentioned, a lot of times the PBMs are under reimbursing independent pharmacists like Edwin, and then over reimbursing themselves for the dispensing of the same drug. I would just be curious, Edwin, do you know if, in this case, a mail order pharmacy owned by the insurance company could provide Eliquis as well?
I'm sure that they have the resource to do it.
Right.
And that was just one example, and there's so many examples.
So like in this case, the patient, do you think that they'll end up having to go to the mail order pharmacy to get this?
Right now, it's pretty much everyone's just out here doing the best they can. You know, they might come to me, they might go to another pharmacy in the community, but everyone has a decision to make. Can you dispense medication that's less than what you are paying for? And if you do that, there will continue to be more deserts of pharmacy and any other business out here. So I'm fortunate because my father had the foresight and the wisdom to invest in our property. But taxes are forever in this country. So at some point, you have to be able to be profitable to sustain yourself.
Right. So that's the, I mean, you heard it from him. They because of that other conflict of interest, which is they own their own pharmacies, they're going to try to drive people like Dave and Edwin out of business.
Do you mind if I
Yeah,
piggyback
please.
onto that answer?
Yeah.
So,
Sir, would you mind coming up to the microphone? Thank you.
So to make it even worse, one of the reasons for the patient steering is this. These companies have become what we call vertically integrated. So you have the insurance company at the top collecting premiums, the pharmacy benefit manager, and then they own their own pharmacies. The Affordable Care Act states, they're called medical loss ratios. They state that in commercial insurance, a insurance company must spend 80% of the premiums collected on health care. So what they do is they take, and Heather can't even get her prescription at my pharmacy, but if she could, they'd say, you have a $1,000 copay at Dave's store. But if you come to the one we own, Accredo is owned by Express Scripts, and Cigna is their insurance company. What they do is they jack up the price of these already expensive drugs 1,000% sometimes, and then that goes, they're taking it from one of their pockets and putting it in the other pocket, and that money is used to satisfy their medical loss ratios so that they can keep more than the Affordable Care Act designed them to be able to keep. So what we have is incredibly intelligent people who can figure out a playing field set in front of them to just funnel all the money into them, and what ends up happening is patients are collateral damage. Local businesses are collateral damage. The federal government, state government, and local governments, in other words, taxpayers, are collateral damage. Again, number 4, number 6, and number 16 on the Fortune 500 list.
So have you, there have been some recent closings of Walgreens in phases. Have you been in any communication with Walgreens to find out, is their problem similar, or are there other problems?
That's a great question. I was actually going to ask you folks, is CVS and Walgreens, not CVS because they own their own PBM, but Walgreens, do you think Walgreens is also kind of facing some of these issues?
Absolutely, absolutely. More have closed in Edwin's area because I'm rural and I don't have one store in a small town. But Edwin could speak to that. How many Walgreens have closed around here?
So presently in my zip code, there are 2 official closed Walgreens, and there's a 3rd one that will be closing. And then the 4th one may be here by spring, possibly summer. So it just adds to the whole scarcity of the pharmacy profession. So you have patients are going to non-traditional places. They're trying to go back to Cook County Hospital or go to some of the different community pharmacies. But everyone is not accepting of the insurance program. Like for one instance, Optum. I don't participate in the Optum network anymore because Optum wants to charge a membership fee. So you have to have a 3-year membership fee. You have to pay $500 up front. So that's $1,500 you have to pay up front to participate in Optum. And then they'll tell you there's still no guarantee that you'll be admitted into their network. So I used this example previously that if you have the EBT or the Link Card program for SNAP food nutritional supplementation, so it's a federally funded program via taxpayer dollars, but all you have to do to be a business is to be licensed and accredited with the city, have a payment system to receive it, and you can accept the EBT. But this is Medicaid. How does a private company can come in and say, well, we're going to treat your health benefits like Sam's Club or Costco, where you got to have a membership to participate in, but I can accept the EBT card and dispense milk or any other food, household items, or grocery items. But for medication, I have to pay a membership fee. It makes no sense at all. And I would say on the side note, please let's not ever privatize Social Security, because if this is the blueprint of what's happening in healthcare, I can see the big financial companies saying that, well, we want to privatize this, we can charge fees for Social Security. So, yes, it's a problem and we need immediate attention.
If I could add a little bit to that. So the Walgreens that are closing the fastest are the ones with a high percentage of Medicaid. Medicaid and Medicare Part D are the worst of the worst reimbursements, forcing pharmacies into insolvency. So what happens in a neighborhood, a Walgreens closes because of Medicaid under reimbursement. Those Medicaid patients then go to different pharmacies and raise the percentage of Medicaid prescriptions being filled at those pharmacies, meaning that the dominoes start falling faster and faster. And we are starting to see the dominoes fall. If we don't fix this soon, it's going to be mail order. And the prices will continue to go up and quality go down. I don't see how anybody other than those massive conglomerates have any interest in seeing this happen.
So they're eliminating the competition so that they control the market.
Oh,
Yes, sir.
yeah, that's
Yes, sir.
exactly what's going on.
Absolutely.
2,000 independent pharmacies close in 2024. And I think there's like 30,000 total in the nation. So at that rate, you're going to see independent pharmacies disappear. And as Dave mentioned, you know, this is one thing that rural and urban areas really share in common, which is those independent pharmacies are the ones that, I mean, you just look around the store. I see pharmaceuticals being dispensed, but I also see food. I see this handy heater over here. You know, I see Listerine. I see everything, because I see greeting cards. I mean, this is like the place you come if you want to buy something, and you know, we have to preserve, you know, Del Car and other independent pharmacies, if for no other reason than, you know, in a desert of food and pharmaceuticals and, you know, other important products, they are kind of an oasis of where people can shop.
So what are some of the barriers and challenges in the state legislature that's preventing these changes? Because I heard you mention something died.
3 letters, PBMs. they are the barrier. I mean, they have tremendous power. It's
That's lobbying power?
tremendous lobbying power. You know, I know that I have a target on my back in Washington, D.C. I know that PBMs are not happy with anyone like me or Republicans who work with me on these issues. But, you know, we just have to do the right thing in this particular case. And it's a no-brainer, because independent pharmacies are small businesses, and the more small businesses you have, the more competition you have. More competition, then the more choices, and the lower the prices for everyone.
Last year in the Illinois General Assembly, we had a commercial bill that would have mandated that PBMs pay all pharmacies the same. Another mandate in it was that pharmacies could not be paid, there was a floor of reimbursement. And I won't get into the complexities of how we are paid, but it's usually the cost of goods plus a dispensing fee. The PBM lobby took that we were asking for a 1099 dispensing fee and sent text messages statewide to the elderly saying, this bill is going to put a 1099 tax on your pharmacy, on your every prescription you buy. Call your representative and tell them to vote no on HB 3435. Did I get the number right?
It doesn't matter.
So it's their not just their lobbying power, because that was an indirect way of lobbying, right? They sent out a lie in text messages. I mean, I had customers coming into my store showing me that. Dave, do you support this? I said, yeah, let me tell you what's really going on. So we are outgunned financially just by, I mean, there are hundreds of billions of revenue a year. We are outgunned. But I think we are getting to a place where we are no longer educating government officials, both at the state and federal level. We just have to get them to have the will to push something over the finish line. And I don't know what the solution is, but I'm hoping it's soon.
Is there an agency that the PBMs are responsible for that monitors them, since they're monitoring these profits? that come in?
Technically, it's many agencies of the federal government, including Centers for Medicaid and Medicare Services, CMS, since PBMs actually do business with the federal government through Medicare and Medicaid. So that's like a great place for us to do some of the reforms that I was talking about. But you know, there are other agencies of the government, including the FTC, and including just other agencies within HHS that can perform this oversight function. And then in Congress, our oversight committee has jurisdiction with regard to this issue as well.
We'll have to cut that for time now, but thank you,
Thank
Edwin,
you.
thank you, Dave, thank you, Heather, for your time.
Thank you.
We so appreciate it.
Thank you.